Well, uh, I could comment on the prior two presentations, but I won't. I was given the task of what will it take. It's almost like a challenge, David. So what will it take? Depends who you ask. So there's this paper that was published not too long ago, I think in 2018 or so, or 2019. And it surveyed almost 900 physicians, both in North America and in Europe. And it sent them some questions to answer. Like I see, it's like 598 were radiation oncologists, 341 were not radiation oncologists. And these were predominantly pulmonologists, some thoracic surgeons, and some medical oncologists. In your practice, how many operable patients? So just to be clear, there are three categories. They're medically inoperable patients. They just can't go to the operating room for any reason. High risk operable patients, and then perfectly reasonable operable candidate. How many operable patients should discuss SBRT as a reasonable treatment option? And won't you know it, you guessed it, 75% of radiation oncologists said that for these operable patients, they should have a discussion about SBRT. And among the non-radiation oncologists, only 40% thought that they should discuss SBRT. Is there a provider bias? Well, you can see that there is. The other question, if we constructed a randomized trial that showed that the difference between SBRT and surgery is less than 5%, and that the quality of life after SBRT would be better, would you agree or strongly agree to enroll operable patients in that trial? These are the numbers. 94% of radiation oncologists said they would, and 62% of non-radiation oncologists said they would not. And for that reason alone, I want to congratulate Drew on the hard job of getting the Valor trial to near completion. So great job, man. So the other question is, would you agree that it is reasonable for operative patients to choose SBRT over surgery? And again, the majority of radiation oncologists said they would, and less than a third of non-radiation oncologists said they wouldn't. So yeah, there is a lot of division in the medical community about where does SBRT fit. Surgery has perhaps not a direct randomized trial comparing it to radiation, as the Valor would, but it's a very long track record of what surgery actually accomplishes for patients with lung cancer. And so obviously the trial that compared lobectomy to sublobar resection put some more heat into the argument, because if lobectomy is equivalent to sublobar resection, which, and by the way, sublobar resection here included wedge resection, why wouldn't wedge resection be just as good as, or SBRT be just as good as wedge? Went the argument, in spite of the fact that we had presented subsequently, the second paper, third paper was comparing wedges to segments to lobes, and this represents the overall survival, which shows that for wedge resection, the overall survival for peripheral tumors was almost 90%. And the mortality of sublobar resection across 83 institutions in Canada and the United States was 0.8%, 30-day mortality. So things have moved since 2016, Drew, and probably the 2016 paper represented a prior era of surgery. So this has already been discussed. The top two trials randomized patients with operable disease between surgery and irradiation. Between the two of them, out of 2,000 planned accruals, 52 were accrued. The second two trials randomized patients with high-risk disease, and both of them closed quickly because one did not accrue at all and the other one barely accrued anything. And then this is the Postel V trial, Rowena, which was reported recently that it also closed because it did not meet the primary endpoint, which is a reduction in local recurrence with SBRT compared to surgery at the interim analysis. And there is two trials that are ongoing. The Stablemate trial, which is in the high-risk patient, comparing SBRT, I assume, to sublobar resection. In the discussion with Drew before the session, the indication is that nobody really knows what's going on with that trial. So Drew, we're all so looking forward to the results of the Valor trial. Okay, so this has already been shown. They pooled the two randomized trials and compared the results of surgery to SBRT. And, you know, personally, I find that comparison is pretty meaningless, but you can make your own decision about that. So what do surgeons look at? There are three trials that I think influences the thinking of surgeons in the utilization of SBRT as definitive therapy in patients who are otherwise good candidates for surgery. The first is the Missile trial, which was carried out by David Palma, who is a radiation oncologist in Canada. And they took patients with stage 1 non-small cell lung cancer, 5 centimeters or less in size, treated them with SBRT, and 2 months later, took them to the OR and resected them. So this is the radiate and resect design, which is really helpful because it showed that the complete pathological response at resection was 60%. So 40% of the patients had residual cancer in the resected specimen. And the argument was then that if you had waited longer, it would be higher, which is an argument that is based on radiation biology, but not on actual data. The grade 3 or 4 toxic side effects occurred in 18% of patients. So it's not entirely benign, and I would submit that grade 3 and 4 toxic events in the CLGB trial were about 14 or 15%, so not dissimilar. And this was the 2-year survival. So you can see the 2-year overall survival. Remember, this is a combination therapy. So 77%. The local control was 96%. Regional control at 2 years was 56%. And the distant control, the freedom from distant recurrence, was 72%. Not great, I would say. Okay, so the other trial that surgeons sort of think about is the SABRE Bridge trial. What is the SABRE Bridge trial? During the COVID years, we were not allowed to operate on patients with early stage lung cancer. So this trial was designed also in Canada. And the idea was we would give them radiation and then operate on them once the lockdown is removed and people can actually be operated on. And it enrolled 72 patients who received SABRE. And of these, about 26 were operated at the time of this, when this paper was published. And the complete pathological response rate in that trial was 50%. So 50% of the other patients had residual disease. And they divided those patients by those that got operated on at 3 months, 6 months, and 9 months. And it seems like the probability of complete path response is reduced the longer you wait, suggesting that some of these tumors had repopulated. Another trial that is important to consider, and mind you, none of these trials are retrospective case series or meta-analyses or what someone said they did or did not do or propensity matched. These are actual controlled phase 2 trials in which we actually have solid data to go by. So this is RTOG 0236 was done by Robert Timmerman in a combination with ECOG, and it was presented twice. The first time in 2010 with the preliminary data, and the second time in 2018 so you can see the median follow-up the first time around was 34 months. The median follow-up in the second time around was 48 months. I don't know why it's written that way. So you can see that there is attrition in the overall survival, and more importantly, in the disease-free survival with extended follow-up beyond the 34 months mark. During the second publication, which appeared in JAMA Oncology as a research letter, the median follow-up was 4 years. The 5-year local failure rate was 20%. And that's an important point because the way radiation oncology defines local failure is failure in the radiation field. The way surgeons define local failure is failure at the resection site or within the index lobe or the hilar disease. This is how we defined it in the CLGB trial. So it's a more expansive definition of local failure. If you define it that way, the local failure rate after SBRT in that trial was 20%. The local regional failure rate, which includes recurrences in the mediastinal and hilar lymph nodes, was 38%, and distant failure rate was 31%, which is consistent with the data I showed you earlier from the PALMA trial. Once again, grade 3 or 4 AEs were 31%, and Bob Timmerman concluded that perhaps there's more work to do. Yeah, so these I had already shown you the 5-year disease-free survival. When we look at the ASTRO, the American Society of Radiation Oncology guidelines, it says for patients with standard operative risks, in whom the anticipated operative mortality is less than 1.5%, SBRT is not recommended as an alternative to surgery outside of a clinical trial, which I agree with, because the long-term outcomes beyond 3 years are not well established. For patients with high operative risk, then it's inappropriate to consider SBRT, and that's exactly what we do when we think that a patient is high risk for whatever reason. So what will it take to slay the dragon? And I think there's just no way around it. I think people hate randomized trials because they take forever, but in order to get it into the seared conscience of all practitioners, you need to have a well-designed trial that shows equivalence, at least equivalence, and possibly superiority. Thank you.